My name's Dominic Power. I'm a consultant hand and peripheral nerve surgeon based in Birmingham in the UK, and I'm one of the editors for Orthoracal Hand, Wrist and Peripheral Nerve. This short video is about the use of advanced process nerve allograft in nerve gap reconstruction, and it's an aid to surgeons in decision making. Following a nerve injury, a nerve gap is the consequence, and this must be rebuilt or bridged after resection of the nerve to healthy stumps. The typical size of nerve depends on the anatomical location. In the hand, in the digit, usually 1 to 2 millimeters in diameter. In the common digital nerve area, 2 millimeter diameter. And then more proximally, at the median nerve at the wrist, a nerve will typically be 5 or 6 millimeters in diameter. There's good evidence to support advanced process nerve allograft in digital nerve reconstruction, but the results of using it in large main trunk sensory nerves or in mixed motor and sensory nerves is more limited. For the surgeon trying to decide whether to include and how to include advanced process nerve allograft in their practice, my own experience is it's an excellent solution for painful digital neuromas or even for acute nerve gap reconstruction within the hand. My use in large main trunk sensory nerve injuries is dependent on the clinical situation. If there's a patient who has a long-standing nerve lesion that's painful and perhaps not in a critical area, I would consider using advanced process nerve allograft because the risk of taking autologous graft from somewhere else in the human body results in a sensory deficit and the risk of a pain driver from a proximal stump neuroma. What about mixed nerves or motor nerves? Well, the data is much more limited. I do, however, use it on occasion. Typical indications would be a very proximal nerve lesion, presenting late or in a poor surgical bed, where the reconstruction is really aimed at perhaps providing some sensory recovery and eliminating the risk of a painful neuroma. And I would supplement it in such situations with a distal motor nerve transfer to a key function that's lost. The gold standard remains using autologous graft for mixed motor and sensory nerve gap reconstruction, but advance really increases the opportunities for surgeons in certain situations. I have used it myself in important mixed motor and sensory nerves with acute injuries, perhaps at the wrist with transection of the median and ulnar nerves. In such situations, again, I would use autologous graft as my primary choice, but occasionally patients come with morbidities that preclude harvest of nerves from the legs. A recent case had multiple sclerosis, difficulty walking, was using a walking frame, and had ulceration and poor quality skin in the legs. In such a situation, Avance is an elegant solution and allows a surgeon to use an off-the-shelf reconstructive method without the risk of causing damage elsewhere. So in summary, for gap management in a digital nerve, using a small single cable of advanced process nerve allograft of perhaps 1 or 2 millimeters in diameter and a typical length of up to 18 or 20 millimeters is usually sufficient. For larger main trunk nerve injuries, I'm more selective, but I do occasionally use advanced allograft in lengths of up to 5 centimeters. Beyond this, I'm less able to predict useful functional recovery. And in a very large nerve, I would prefer to use advanced process nerve allograft in a cabled fashion to allow a greater surface area to volume ratio to allow rapid revascularization from the bed. Thank you.